It's my pleasure this morning to introduce our guest speaker today, a long-standing friend of mine, Dr. Melanie Thompson. And I was going to do this extemporaneously, but I thought it was nice to read what is actually in her brief biography. And it's brief, but impactful. So Dr. Thompson has led over 400 phase 1 through 4 studies in the area of HIV treatment, prevention, and diagnostics in her role as the principal investigator of the AIDS Research Consortium in Atlanta. And as part of that activity, she also has been a primary HIV care provider for more than 35 years in that practice and contributed heavily to the development of almost everything that we're using for treatment and prevention in HIV these days. She serves currently on the IAS USA guidelines panel for antiretroviral therapy and joins myself and Davey Smith on that panel, which is great. We've been working with her for several years in that activity. She also has served an 8-year term on the DHHS guidelines panel for antiretroviral therapy for adults and adolescents. And in that role has led the country in terms of issuing guidance for how to use antiretroviral therapy in the modern era. She also currently co-chairs the HIV Medicine Association IDSA primary care guidelines for treatment of people with HIV, and is the chair of the Ryan White Comprehensive Planning Committee for Metropolitan Atlanta. That's a mouthful, and serves on the mayor of Atlanta's LGBTQ plus advisory committee. So she's had many roles over the years in leadership roles, including being the past chair of HIVMA, the HIV Medicine Association of the IDSA, and has broadly led a number of very impactful efforts for raising the visibility of HIV care and treatment nationally and internationally. So Melanie has worn many hats over the years, and as one of our country's premier HIV clinicians and researchers, it's my pleasure to introduce her today to talk about 2025 and beyond. And who better to talk about that than someone who's been involved in the whole research and treatment era since 1987. So
I thought you were going to say someone who's so old.
We're not old, we're just seasoned.
Well, thank you so much, Connie, for that nice introduction, and thank you all for coming out today. I will start by just saying that my financial disclosures probably not too relevant for this. I chair an IDMC for a CRISPR study for HIV cure. Not going to talk about cure today, not going to talk about prevention today very much. This is really all treatment. And then the learning objectives, I hope you'll be able to discuss some of the investigational treatments, particularly islatravir, lenacapavir. Wait a minute, this is getting ahead of me. Wait, stop. It has a lot of its
sticky sometimes.
and agents in the HIV treatment pipeline. So now I'm in control again. That's good. So we're going to talk about 2025 and beyond. And really, this is on some sort of a timer that's not controlled by me. Here's the menu. These are the old classes of drugs, okay? And it represents not all, but many of the compounds that are currently in development. So we're not going to go over all of them. This is going to be sort of 30,000 foot view of most things. We are going to have some co-formulations to look at. There was a maturation inhibitor in the pipeline until recently, and the development of that has been suspended by ViiV, although they say it's not killed yet, but it doesn't meet their criteria for long-acting therapy. So we're not going to talk about that. There are a lot of bNAbs out there and anti-CD4 monoclonal antibodies, talk about a few of those. And just in this slide, there are more than 26 unique agents, and we're going to be seeing oral weekly dosing. We're going to be seeing injectables every 3 or 4 or 6 months, implants, and potentially vaccines. Connie haven't done vaccines that I'm not going to talk about, but we're going to see a lot of new approaches. So let's start with islatravir. Islatravir, a nucleoside reverse transcriptase translocation inhibitor in our TTI, has actually been in development a long time. And that's because there have been some problems with islatravir. We're going to go over a couple of studies, but I wanted to just back up and be sure that everyone understands what happened with islatravir. So islatravir is appealing because it has a very long half-life, 191 hours. But the problem is that the good thing and the bad thing is that it persists in the cells a long time. The triphosphate form is the active form. And because of a variety of mechanisms, it accumulates inside the cell. And it turns out that this can be toxic to the cells, cause lymphocytic apoptosis, and then lymphopenia as a result. And so this is why islatravir went to the sidelines for a while, was on clinical hold for PrEP as well as treatment. This slide sort of encapsulates those issues in terms of PrEP. You can see with the green bars, lymphopenia given at 60 milligrams once a month for PrEP. The PrEP studies have been entirely discontinued. On the other side, doravirine and islatravir at a dose of 0.75 milligrams a day also cause lymphopenia, the green bars, and that was put on hold. It's now back and running with a lower dose. And in the middle, this is a study in combination with MK-8507. We'll talk about that a little more in a minute. 20 milligrams a week of islatravir for treatment. And these are different doses of the 8507 that looked like 8507 was the culprit here. Turns out that's not the case. Merck did a lot of studies and it was unfairly blamed for the islatravir lymphopenia. And is now being brought back into the pipeline for development. It even has a name, ulinivirine or ULO. And we'll be seeing more of ULO. This is a drug that is similar to doravirine. It has a longer half-life, like about 70 hours. It has good HIV reduction over 7 days. Resistance similar to doravirine, not a lot of drug-drug interactions. And once weekly dosing is the way that this is going to be moving forward, to be paired with an NRTTI that Merck has yet to name. So let's go back and look at the doravirine islatravir studies. I'm not going to present the phase 2 results, but I just want to show you the phase 3 studies. Suffice it to say, phase 2 was good enough to go on to phase 3. So there are 2 studies for people with viral suppression. One compares dorislatravir to baseline antiretroviral therapy, and then there's a delayed switch at week 48. The other compares doravirine islatravir directly to bictegravir FTC-TAF for 48 weeks, and then there's a switch at 48 weeks. And we are told that the 48-week results will be coming in the first half of 2025 for this study. So we'll be hearing more about this hopefully soon. And then there's a treatment naive study. It has lagged behind a little longer. Compares doravirine islatravir in a placebo-controlled manner to bictegravir FTC-TAF. We had a sentinel cohort for enrollment, so that they were initially only enrolling people whose viral load was less than 100,000 copies, and then opening it up to people who had higher viral loads. And so this enrollment has now been completed as of November 2024. So we don't have any results from that yet, but hopefully we'll be seeing things this year, at least from the week 24 time point. Okay. And just a note about resistance with doravirine and islatravir. There are a lot of reasons that Merck would want to put these drugs together, particularly because they own both of them. But there is synergy between the two drugs, and the M184B, which is the most frequent substitution associated with islatravir, doesn't really kill islatravir. It's a modest hit to its activity. But there are some resistance-associated mutations that appear to confer hypersusceptibility. K65R confers hypersusceptibility to islatravir and doravirine in some cases. And then the F227C mutation for islatravir also confers hypersusceptibility. And our old friend M184V or I also has a hypersusceptibility effect in some studies with doravirine. All right, so let's look at islatravir plus lenacapavir. These are 48-week results that were presented in Glasgow at the end of last year. It's a phase 2 study. People in this study had viral suppression on BF-TAF for at least 6 months, no virologic failure. And the randomization was to islatravir at 2 milligrams. You remember how high the dose was before, so we're down to 2 milligrams with 300 milligrams of len, randomized against BF-TAF, and then an extension phase after week 48. The primary endpoint is week 24. So I want to show this slide. It's the only demographic slide I'm going to show. We have good diversity in the study, which is important, but look at this. This is really about the only study I've seen recently that actually puts gender identity in the demographics, and that means you have to collect those data up front, but they're really important. So those of you who are designing studies, remember to capture this up front because we need these data. Okay, so here's the primary endpoint from this study, week 24. And the results were excellent, 94% viral suppression in both arms. There was one person who actually had a suppressed virus at screening, but on day 1 had 250 copies of virus, and that persisted until about week 24 and then spontaneously suppressed. So no changes were made. And then the week 48 result also shows a very similar result, around 94, 92%. And there were no individuals with virologic failure at week 48 in the study. And I showed you the one that had a little blip, more than a blip, who wasn't suppressed at baseline, I would say. And then there were a few participants with no data in the window. Boy, I'm sorry about this. I'm not changing things. They're just changing themselves. There were some participants with no data in the window, but nothing because of virologic failure. So here's the money slide when you talk about islatravir, and that is that there were no lymphocyte count differences between the two arms. Okay, so islatravir is not associated with lymphopenia in this study. CD4 and total lymphocytes were pretty comparable. All right, I'm not going to talk a lot about safety in this study, but in this talk, but I do want to point out one thing. For the safety results for this study were pretty normal. Nothing to talk about. Well, this is throwing me off my game here. Nothing to talk about in terms of safety, except laboratory abnormalities. And the laboratory abnormalities really showed one thing that I want to point out. There was an elevated ALT in one person in the dual arm study, and that was acute hepatitis B. So acute hepatitis B should not happen. But when you put people on a 2-drug regimen where there is no tenofovir, then unless they are adequately vaccinated, they are at risk for hepatitis B. Or if they have hepatitis B and you take them off of a regimen and put them on a 2-drug regimen, that's a bad thing. So this is just a flag for all of us. that two drug regimens without tenofovir do not control hepatitis B. So vaccinate and pay attention to hepatitis B. Here are the body weight and BMI changes through week 48 for this study. Really no difference between the arms.
I think it's just very sensitive. It like feels the heat off your fingers. I think exactly.
There wasn't any heat in my finger.
Not here.
Definitely. Clearly.
I always worry about PC to Mac differences. I'm a Mac person. You guys are Mac people, but didn't do this on my Mac, so maybe it's just me. Anyway, so no metabolic issues of concern in terms of weight or BMI in this study. So I do want to mention 8527. This is the oral NRTTI being developed by Merck. It's similar to islatravir. Again, active form is the triphosphate, not a lot of drug-drug interactions, but it has a half-life of over 200 hours. And this is suitable from the PK studies for oral weekly or monthly dosing. And in single dose studies with people with HIV, there was a good viral load decline, even at a low dose at day 7. And this is being pursued as oral PrEP, once monthly oral PrEP. And here is a study presented in Glasgow showing 100% protection against rectal simian HIV in rhesus macaques. So that's a good premise to start with. Here's the phase 2 study design, looking at 3 doses of 8527 compared with placebo. And this study should have primary endpoint results at the second half of 2025. All right. There's also an islatravir prodrug. Gilead and Merck are working together on the islatravir studies. Gilead has this compound, GS1614. This is being developed for injection every 3 months, and it's in phase 1. And the idea is that they will pair this with a Gilead INSTI called 6212, also developed for injection every 3 months. And both of these are in phase 1. All right, let's turn to lenacapavir. This, of course, is a capsid inhibitor that is approved for people with treatment experience and multi-drug resistant virus. And also the blockbuster results of the PURPOSE 1 and 2 studies I don't have to tell you about, which is good because I'm not talking about prevention. But nonetheless, we hope that will be approved very soon by the FDA. See no reason that it won't. So I want to go through a few of the studies with lenacapavir. Here is a 48-week study with daily bictegravir and lenacapavir in a population that has viral suppression, but on a complex regimen. And so what does that mean? Complex, we'll get into that in just a second. But I want you to see the study design. Bictegravir as a single drug, not a combination, is being given at 75 milligrams, along with either 25 or 50 milligrams of lenacapavir. And those are compared to the complex regimen that people are already on, and then there is a rollover extension. And the 2:1 randomization gives us a little more robust analysis. At 48 weeks, they will switch. You notice these are 2 separate drugs. There is a fixed dose combination that has just shown good bioavailability in the study presented in Glasgow. And so there is a switch at week 48. So what is this complex regimen business? Well, we all have these patients, don't we? We all have a few patients who, in this definition, are on a boosted PI or in an RTI plus 1 agent at least from another class, not nukes. Or they could be on at least 2 pills a day or dosing more than once a day. Or on a parenteral agent, not a complete treatment regimen, plus some oral agents. So that's how they define this. This is what it looks like. It's kind of a potpourri of everything you can think of. But overall, 72% of these were on a PI, and 2/3 of those were on a PI plus an INSTI. You know, this is something that we all try to figure out how to simplify, and many of these patients haven't had a lot of options. So here is the result at week 48 for this study. You know, when you do a switch type study, the people who are on their regimens and doing well enough to be in the study generally do well throughout the study. So we have 100% response in the comparator arm, but pretty good response, 90% or higher in both of the bictegravir and lenacapavir arms. There were a couple of people in the 25 milligram dose who had blips but resuppressed spontaneously. There was one in the 50 milligram arm who required a change of therapy. This is encouraging. I want to show you the metabolic changes in this study because they have a metabolic sub-study. And you can see in the blue bars that for the BIC plus LEN arm, there was a decrease in total cholesterol, LDL cholesterol, triglycerides, and the ratio total to HDL cholesterol. So compared to the red bar, which is staying on their current therapy. But there really weren't significant metabolic changes in terms of glucose, weight, and BMI over this 48-week period. You know, it looks like there's something happening there, but it wasn't significant. So the jury will be out on this and explore it in further studies. There were some treatment emergent adverse events, not a lot that were concerning, some nausea, some vomiting. There were some serious adverse events that were unrelated to study treatment. Unfortunately, one death associated with coronary artery disease. They also provided data in Glasgow about treatment emergent metabolic disorders. So I think that's an interesting way to present outcomes. And they were pretty similar across the arms, except in the 50 milligram lenacapavir arm, there were 6 individuals who developed hypertension during the study, not statistically significant. And if you look at blood pressure at week 48, there was really no significant change in from baseline for systolic or diastolic blood pressure between the arms. So I think it's good that we're beginning to get these kind of output analyses. So Dr. Little was the first author for this study that was presented in Glasgow. And so I'm sure many of you are familiar with this study. Lenacapavir is given with 2 broadly neutralizing antibodies, teripalimab and zenlibrumab, mercifully called TAB and ZAB at this point. And they studied these antibodies in this study in individuals who had sensitivity to one or both of the antibodies. And so, you know, why would you want to study virus that was sensitive only to one of them? Well, it turns out that only half of clade B viruses show sensitivity to both of these, and 90% are susceptible to one or the other. And here is the study design. Sensitivity was performed before the study, before enrollment in the study. For this particular study, there are 2 cohorts, those who had sensitivity to both TAB and ZAB, and those who had sensitivity to only one. And both of these cohorts were randomized to a low dose or a high dose of ZAB. So 10 milligrams per kilogram or 30 milligrams per kilogram, and everybody got lenacapavir and TAB. So here is how that's sorted out. And what you see is that there. In the low dose and the high dose group, There were 11 and 10 people respectively that had sensitivity to both of the BNABs. And then you see the numbers here, 2 and 3 that had sensitivity to only 1. So we're talking about small numbers here, but an interesting way to look at these antibodies. And it turns out that there were no virologic failures at the high dose of ZAB, 30 milligrams per kilogram. There were a smattering that we'll look at in the 10 milligram dose. There were some treatment emergent adverse events, and they were mostly associated with injections and some COVID and respiratory infections. So here are those individuals with virologic rebound. Again, all of them were in the 10 milligram group. And what you see, this participant number 1, who at 12 weeks broke through, started oral ART at that point. And this individual actually selected for a resistance mutation for lenacapavir. So the other 2 who had some blips did not have any detected resistance to lenacapavir. You know, lenacapavir is not so robust in terms of resistance, so we're going to have to watch it really carefully, I think. This is the phase 2 study design that is moving forward with viruses that are sensitive to both BNABs. And they are using the higher dose of ZAB and comparing it to people who are staying on their baseline oral regimen. Then there's a switch later on at about a year. So it will be interesting to see what this looks like with slightly higher numbers, but not a lot, a total of 75 people in the study. I do want to just show you briefly that there is a prodrug of lenacapavir, just like there's a prodrug of islatravir. This one is called 4182. And these are very early data of single dose and multiple ascending dose SAD and MAD studies. This is the SAD study. Not so sad because the half-life was 11 days, which is pretty darn good. They looked at 200 milligrams and 600 milligrams in this single dose study. And when you go to the multiple ascending dose study, you see weekly dosing, and at about 36 days, really at about 30 days, there was a lot of accumulation. At 36 days, maximum accumulation. And so dosing was stopped at that point. And you see sort of a slow trail off, indicating that there is a pretty long half-life for this drug. So they have chosen 300 milligrams, hoping to hit the sweet spot between 200 and 400 milligrams to move forward with this drug. And there was a study in Glasgow showing that when a PPI was given with 4182, there was no effect on lenacapavir concentrations. So that's good news. And what are they going to do with 4182? Well, Gilead's going to pair it with one of their own drugs, of course. And that is 1730. So this is a weekly oral INSTI that is in development. And it is going to be compared, it's going to be paired with 4182 and compared against Bictegravir FTC TAF in a phase 2 trial. And this will be in individuals with viral suppression. And Carl Fichtenbaum presented these data at CROI last year. So I want to give you a little more information about 1720. First of all, in the phase 1 study, the data I'm not going to show here, the median half-life was 9.4 days. So pretty good half-life. And then this phase 1B study looked at 4 different doses of 1720. And here are the results. And actually all of the dose levels at day 11, okay, produced a virologic response that was greater than 1.5 logs. So that's pretty good. But for the highest doses, 400 and 900 milligrams, we were really approaching 2.5 logs. So that's awfully good for an 11-day study. And we have an abstract presented in Glasgow showing that there was no treatment emergent INSTI resistance in any of these cohorts, even the lowest dose. So that is reassuring. And phase 2 is going to use 650 milligrams, again, looking for a sweet spot between the doses that were actually studied. And speaking of INSTIs, what about our old friend cabotegravir that we hate to give every 2 months or every 1 month? Well, now they're looking at ultra-long acting cabotegravir to be dosed every 4 months. And this is the study design. They looked at sub-Q cabotegravir with hyaluronic acid to hopefully allow higher dosing and slower release, but it didn't work. And it didn't work because the injection site reactions were so bad. So this has been discontinued due to the injection site reactions. So we are going to look at part C of this study, which looked also at sub-Q dosing, but without hyaluronic acid, as well as IM dosing at several different dose levels. And so here is the PK study of ultra-long acting CAB. It was looking at 800 milligrams and 1200 milligrams, both sub-Q and IM. And I think what you can see here is that, or you can barely see it because it's so small, but the IM dosing achieved higher levels than sub-Q. You can also see in this graph, the dotted black line is what I'll call old CAB, and the red line is an IM version of CAB. And you can see that there is a lower Cmax and a flatter curve for this dosing regimen. And then they switched the colors on us here, which is not nice, but this time old CAB is red and CAB ultra long acting is black. This is a PK simulation. Stop that. This is a PK simulation that shows every 4-month dosing, and a higher exposure is predicted than for old CAB with a half-life that's about twice as long, which is what you want. And then this is the result in terms of adverse reactions, injection site reactions in particular. And you can see that the IM was better tolerated than sub-Q. Most of the nodules were grade 1, but there were a lot more of them in the sub-Q arm, and they lasted longer. So ultra-long acting CAB is moving ahead in phase 1. We'll hear more about that probably pretty soon. Okay, now let's go back. N6LS is a CD4 binding site, BNAB from bees. It there are several studies presented at Croy and at Glasgow with that, and we'll go through a little bit of those data. So these are the data that were actually presented in 2023 showing the study design. And a single N6LS infusion was given in part 1 at 2 different doses. And then in part 2, 3 other different doses. And so we're going to look at those. First, we'll look at the sub-Q antiviral activity. And I will just say that I hate the way they present these data, because they present data for 40 milligrams per kilogram, but then that's compared to a milligram dose, which actually is very different in terms of milligrams per kilogram. So what you can see if you look at the purple is that the sub-Q has a much lower nadir than, or a higher nadir, less virologic suppression than the IV dose at the same milligram dose, okay? So the viral nadir was about 0.5 logs for sub-Q, 1.5 logs for IV. And this is probably because of first pass elimination. Now, the SPAN study presented in a poster at CROI did look at sub-Q for this compound with hyaluronic acid, and actually there were frequent injection site reactions, but they were relatively mild and they were tolerable. So this is moving forward in a sub-Q dose in the EMBRACE study. Now we'll look at the IV dosing for this compound, and what you see all the way over at the bottom of the slide was a 40 milligram per kilogram dose, which had a viral nadir of about 1.7 logs that occurred at day 16. And it took until day 35 to see a rebound. So that is encouraging. And the EMBRACE study, which is a phase 2b study that is going on now, is looking at 60 milligrams per kilogram IV, higher than 40 milligrams per kilogram, but there were no safety issues. They felt it was appropriate to go up higher. So N6LS is being given IV every 4 months, CAB once a month. And then this is the sub-Q dosing arm with hyaluronidase, and that is 40 milligrams per kilogram sub-Q, also given every 4 months, along with CAB every month. And there was a poster on resistance at the Glasgow meeting that basically looked at the in vitro phenotypic results, and the IC90 value correlated with exposure and achieving EC50. And the phenotypic sensitivity in this study actually decreased over the course of this fairly short period. But then when people added other drugs and virus was suppressed, it did not decrease anymore. All right, so let's talk about a bunch of BNAbs that were presented at CROI. First of all, a combination with CAB-LA, VRC07 523LS, trips off the tongue. This is the 44-week result. And the virologic results were pretty good, only 7.3% virologic failure, but this occurred in spite of good levels for CAB and for the BNAb. And there was one individual who had a high IC50 to the BNAb and who developed an NST-resistant mutation at the time of virologic failure, 263. So that's not particularly encouraging, but not unexpected, actually, particularly when you're using a single BNAb. All right, so there was a triple BNAb study. I'm not going to read off all those letters and numbers to you, but they were given every 4 weeks in this study during an analytic treatment interruption. And so these individuals were starting with suppressed virus. 83% maintained viral suppression during the 28-week dosing period. And then after the dosing period, there were 36% who continued to have viral suppression out to week 44. So that's kind of interesting, and we'll see where that goes in a larger study. Unfortunately, not so good for the trispecific BNAb that was studied in a very small number of people, but in 7 people who had viremia, the RNA reduction was really between 0.4 and 0.7 logs. So not really very encouraging for this particular BNAb. So I want to spend my last few minutes doing a really rapid roundup of some drugs that are deeper in the pipeline. So if If this was a 30,000 foot overview, this one's 40,000 feet. So, but I just want to mention the names. So, there are two capsid inhibitors, more capsid inhibitors, this time from ViiV, in the deliciously named cinnamon study. I don't know what it stands for, but nonetheless. So there has already been a first time in human study, people without HIV for both of these compounds, showing that they had a very long half-life, 156 hours, 64 hours for the tablet formulation, making them suitable for once weekly dosing. So you see where things are going here. People are looking at oral for weekly dosing as much as possible. Not anything of note with drug-drug interactions. And there has been a 10-day monotherapy study completed. We don't have those results yet. You might see them at Troy, who knows? There also is in an RTI at Gilead, bavtavarine. It's in phase 1. It also is in the 10-day monotherapy study, which the recruitment is completed. I think the study is completed by now, but there are no results yet. And this is going to be active, we hope, against other NNRTI resistant viruses, and is suitable for weekly dosing according to the PK. Very interesting compound. Who knew we would ever see an unboosted protease inhibitor again? Not that we ever really had one in absmanavir, but that's another story. Anyway, 9770 is in preclinical development at Gilead. It is guanidine based rather than an aspartic protease inhibitor. The preclinical PK looked good, long half-life, 6 to 12 hours. And has in vitro activity against many of the resistance mutations that we see with darunavir and absmanavir. So this is interesting, preclinical, but moving along. Okay, so we have a bunch of new INSTIs. VH184 is from ViiV. It is in phase 2. It is active against dolutegravir resistant viruses and should be injectable every 6 months, perhaps longer. A proof of concept study was completed in June. We don't have those results yet. Again, this was a 10-day monotherapy versus placebo trial. They also did a randomized study of sub-Q versus IM formulations. So we'll probably be hearing more about this fairly soon. I thought this was interesting. This is in the preclinical space, but it's ultra long acting pro-bictegravir, okay? And what's interesting about this, first of all, it's they're looking at injection every 6 months. But look what happens. These levels are very steady up to the 6-month period, and then they plummet. So it doesn't have that PK tail that causes us so much angst with cabotegravir. So I think that was an interesting aspect to this, but of course, we're talking about rats and cats. Here are 3 INSTIs in the pipeline at Gilead. 2 of them are injectable every 6 months, 6212 injectable every 3 months, all in phase 1. And there is an ultra long-acting pro-cabotegravir called XVIR 110. It is in the preclinical space. They're looking at injections every 6 months or perhaps less frequently. And again, we're seeing PK in rats and beagle dogs. So stay tuned. And then this is a 50,000 foot view, just to tell you that there is another INSTI in preclinical at ViiV. What about implants? Well, this has not been a rousing success so far. Unfortunately, the TAF implant that was being studied by the Caprisa group in women without HIV was not tolerable, had to be removed in about a third of people because of local reactions, and drug delivery was lower than expected. However, there is a dolutegravir implant in mice. It delivered adequate levels for 6 months, biodegradable and removable in mice. But it's moving forward. The CAB implant has pretty much been abandoned. All right, so I wanted to end by giving you a little tease about UB 421. We don't hear much about this drug, United Biosciences. It is a humanized IgG1 monoclonal antibody. It binds with very high affinity to domain 1 of CD4, and it showed maintenance of viral suppression during an analytic treatment interruption for 8 to 18 weeks. That was published in Ancient Days 2019. And you see that study here from the New England Journal. So there has really not been a lot published on this drug, this antibody, not a drug, until now, last week. So this case was brought to my attention by a friend at the clinical center, Alice Powell, some of you may know. This is a 58-year-old man with KS and lymphedema. His viral load was really high, 295,000, but his CD4 was really low, 23. And so he was in jeopardy, and the punchline. So his virus was truly MDR, okay? Resistant to all nukes, all NNRTIs, all PIs, INSTIs, all INSTIs. He had been on ipilimumab, resistant to that, fostemsavir, resistant to that, and multiple BNAbs, also resistant to them. So what did they do? So basically, they gave him UB 428 that they got through expanded access, and he, along with lenacapavir, they gave weekly UB 421, and then lenacapavir every 6 months, with a dramatic virologic response and viral suppression beginning at about 52 weeks and carrying on for another 20 weeks at the time of this publication. And then CD4 went from 23 up to 80. So this is a win for one individual, but doesn't it give us hope? Okay, so where are we in 2025? Many paths to weekly oral dosing. This is something we're going to see. Many regimens are going to consist of only 2 drugs. These long-acting injectables are going to be for at least dosing every 3 months. The sub-Q injection is tough as the volume increases, and the goal is going to be self-injection, of course. BNAbs and monoclonal antibodies are still looking for their niche, but are some promising data with lenacapavir. There are lots of promising compounds in the pipeline. Cost continues to be a challenge and an opportunity for advocacy. And equity of access really has to be prioritized to end the epidemic in all people. So I'm going to say thanks to Susan for inviting me to speak today, even though she chose Hawaii over me. To the participants, the investigators, sponsors, staff, who did these clinical trials. And I can't end a talk without talking about advocacy. So the federal budget is back on the table, and the continuing resolution will expire on March the 14th, and all of our HIV funding is at risk, okay? All of it. So please urge your senators, your representatives, to protect the HIV budgets for Ryan White, that's HRSA, for the End the HIV Epidemic Initiative, which was zeroed out in the House budget, for the NIH, for CDC, for housing opportunities under HUD. Please urge them to reauthorize PEPFAR for at least 5 years, and let's advocate for lower prices for these drugs and shine a light on disparities and the need for equity. So I've gone a little over my time. I'll stop there. Thank you.
Yeah, I was going to open it up here. There was, I think, a quick question in the chat from Katie Riggs. Oh, did someone raise their hand already? I'll let your mentee first, the first question. Katie asked about the long-acting Probic, that sudden drop. She said, how is that physiologically possible? Is there any understanding of why that occurs? It's
I,
very interesting.
it is very interesting. I'm not a rat or macaque physiologist. And, you know, this is an animal study, so it could be very different in humans, and I can't explain it. So, sorry, Katie, great question.
So, Scott Tender, beautiful presentation. It's just so impressive to keep so much information organized. So thank you for all of that. A lot of my questions have to do with stuff that probably falls into phase 4 testing. So maybe not germane, but the thing that I think maybe that is germane is, you know, with all these long actings, I'm a little too fear-based. I worry about adverse events, particularly longer term. So I've been reassured by some of the data that have been coming out showing not a very high or not a rate of adverse events and not very serious or life-threatening. But that whole idea of, you know, once we give someone a long-acting therapy, we can't get it back out. You know, and so what discussion has there been among the manufacturers and the guidelines committees and so on about, you know, tracking that and concern about that? And
You know, you're not the only one who's fear-based about long-acting therapies. I share a certain amount of skepticism, and patients are also fear-based about all of this. You know, I tried to put a patient on lenacapavir the other day who really, really, really needs it and just absolutely frightened to death about taking something that we couldn't get rid of. You know, to me, where that frontier is really looking at the field of implants where you can remove them. So I think implants that you can't remove are not going to be much of a go. So removable implants. And, you know, I think, I don't know what to do when somebody has an adverse event way out after taking cabotegravir. Is it due to cabotegravir? I don't know. And I think there are some observational studies. There are cohorts, not a big major cohort that is going to yield a lot of information, although your 500 patients on long-acting therapy might be a great place to start. So I think defining what these might be is really important, and being able to mitigate as quickly as possible. What I worry about equally is the people who are disappearing, and they're just not coming back in time. And you spend a lot of time trying to get people to come back. And I think that's also a real issue.
Do you want to go at the same time? I'm just kidding.
Let's go at the same.
Want to do what you
Whichever.
want?
I was just gonna say that a lot of the adherence work is traditionally focused on daily ART. So I think just for people in global public health and more of our social science researchers, I think there's opportunities to now plan how would you support adherence for every 6-month injections, weekly oral, because I mean, maybe there's literature out there, but I think it's a nice opportunity for study. And I thought for the implants, people were not excited about it, like the actual target.
I think not. I mean, I think, you know, they're still doing the research, so dolutegravir in rats, but they are still doing the research. I don't think the implants are going to answer this question of long-acting therapies. But, you know, having sentinel cohorts that can define adverse events, I think is one of the better ways to get out after that and help us understand it. Connie.
Yeah, so just on that topic, I think one of the issues with sentinel cohorts is people just follow the adverse events and the symptoms without linking that to actual PK or PD data that might be important.
Right.
And so I think every time someone puts together an observational cohort or one of these sentinel cohorts for adverse events of long-acting therapy, there needs to be a drug level obtained at the time of that adverse event so that we understand what we're looking at here. I think that's critically important as we plan future observational cohort data for these long-acting drugs. And that's not being done right now. So I think there's another good opportunity for research but not just on adherence, but on adverse events and what they're related to with some of these
Do
long-acting
you mean in the
drugs.
clinical trial or in observational cohorts?
Pardon?
Do you mean in the clinical trials or in observational?
Both.
cohorts? So,
I think it's necessary in both.
I mean, the cohorts don't, have the money, and so would you collect like a hair or dried?
I think
hair specimen or
there's-
Dried blood spot or?
Yeah, there's a good opportunity for a lot of these types of measures where it's not expensive, except to run the PK, but collecting a sample that you can store and be able at some point to look at the relationship between drug levels, not just in blood, but in tissue where a lot of these drugs accumulate.
Mhm.
And being able to evaluate that in the context of longer term adverse events that we see with these drugs.
Just
That's
as-
the only way we're gonna get data on what's really happening.
And, I think also in the prevention studies. Where
Exactly.
it's much less muddy. So
Right.
people aren't on 12 other drugs and, this and that and the other, and I think,
Yeah.
those are places that really could have a lot of nested studies.
And then just going back to your point about equity, so there's a very nice opinion piece in the New England Journal this past week from Linda Gale Becker and colleagues from South Africa on long-acting agents in development and specifically talking about the prevention field, because as you know, the HPTN studies that showed 100% prevention of HIV transmission with these long-acting drugs in both men and women. And those studies were done all over the world, but those drugs are not accessible anywhere in those areas where the studies were done. And so I think it's important for those of us who do participate in or design clinical trials we really need better advocacy for companies that are developing those drugs. We can't have a $20,000 a year drug and have it be useful in helping us end the epidemic and decrease transmission and decrease the consequences of HIV globally.
Yeah.
So there needs to be forward planning in that regard as well.
I think that's right. The forward planning part is
Yeah.
key,
Yeah.
because you can't come after the fact and say, oh, that worked. Now what are we gonna do?
Well, this
have
article
to have
had
a
some
plan.
very nice suggestions, and I think critical for those of us involved in the field to look at and advocate for with companies, because I think they're very important points being made.
And
I
I
do
just,
think that the ACTG has made recently a lot of progress with moving forward with the lenacapavir cabotegravir study internationally.
yes,
And I don't think it'll be very long before we're switching out cabotegravir for the V184, which will treat resistant people with dolutegravir resistance globally. And, it would be amazing to have a twice yearly injection that's affordable, and I think it's feasible.
It is, this makes the point that it costs $40 per
Yes.
person per year to make lenacapavir and cabotegravir. So there's no reason why you can't, on mass production, reduce that cost and make it available.
that's
So
right. I think if a couple of CEOs gave up. their
just
salary-
requires, exactly, maybe that $1 million they gave to the inauguration could go someplace better.
Maybe, but, and I just want to tag on to that very briefly, because I know we have.
It's
we're running
9
out of
o'clock.
time.
It's okay. I can talk to you about it later.
But, so, I live in the global south, Atlanta, Georgia.
Yeah.
And I've got to say, equity is a huge problem here in the United States. And the people who are getting prevention modalities are gay white men. We're just not seeing that equity translate here in the US, women, people of color.
I'm not gonna
And-
see it in the future.
Yeah, I know. I think, this is one, I just want to say our voices are important, people, clinicians' voices, scientists' voices are important. So, do your mourning about politics, but then don't put your head in the sand. It's important that we get out there and make our voices heard. And, they do pay attention. Sometimes they ignore it, but they do keep up with what constituents and, we have to make good trouble, as my congressman, John Lewis once said. So, we have to be advocates for our patients. So.
I mean, I do want to I remember the last time during the Trump administration, the four pillars of end the HIV epidemic, that's when that all really emerged.
I know.
And so, you know,
amazingly.
and so hopefully to say, continue the work that he started. It sounds horrible, but you know, I mean,
Well, you know,
I don't
that's it.
necessarily assume that's gonna be.
And advocates have, you know, there's a letter going to the administration basically saying, you started this, let's support it. You know, I know that one of the things that encouraged this to even happen was Alex Azar, Bob Redfield, Tony Fauci, you know, really pushing, but also saying, gee, Obama couldn't end the epidemic, maybe you can. So, I mean, you know, you have to do what you can, but the House Republicans have zeroed out in the epidemic budget, in their part of the budget. Now, you know, the Senate gets its say, but the Senate's a little shakier than it used to be a few weeks ago, so, yeah.
The other issue we all need to be aware of is the Supreme Court is now considering the legality of providing free HIV drugs in the Ryan White program and in the PEPFAR program, as well as in the Obamacare Affordable Care Act. And if they rule in the wrong direction, we will no longer have access to care even for many people in the US. So
Yeah,
that's an important piece of information to be following.
well, that's right, and, you know, it has to do with some arcane issues about the US Preventative Services Task Force. And
Exactly.
how they're not real, they're just volunteers, they're not federal government. So, you know, these are legislative things that could be done in a perfect world. But I think we, you know, keep your eye on the Supreme Court for that, because it also is not just HIV, it's other preventative care
Yeah.
under the
Any
Affordable Care Act.
preventative care under the Affordable Care Act.
So, overstayed my welcome.
No, you didn't.
No,
It was
not
great.
yet.
Thank you.
It's been such a pleasure, really awesome.
Are you meeting with someone right now, or was it